Okay, our next speaker is Dr. Jenny Tsao. She's an associate professor in the UCLA pediatric, now we're talking children, pain program, Department of Pediatrics here at UCLA. Her research interest centers on the relationship among pain, anxiety, drug use, and health outcomes, including pain-related functioning and utilization of conventional and alternative medical care. And she's focused on the role of anxiety in children's experience of pain, including acute laboratory pain conditions and chronic recurrent pain. Okay, please welcome Dr. Tsao.
Thank you. So I'm actually filling in for Dr. Lonnie Zeltzer, who is an internationally renowned expert in the treatment of pain in children and young adults. And she has done some of the pioneering work on the use of hypnosis in children with cancer undergoing painful medical procedures. And so just to disclosure, I did not compile these slides, so hopefully I'll be able to answer questions, but you know, I don't have the same background in cancer that she does. The research population I work mostly with are children and young adults with chronic non-cancer pain. So children who, for example, have chronic stomach aches or headaches that are not explainable by traditional medical diagnoses. So that's a little bit of a different population, but I think there's a lot of overlap in terms of the kinds of approaches that work well for both populations. And part of my talk is also going to be talking about the nature of pain itself, which of course is an experience that is in common with both children with non-malignant, non-cancer pain and children and adults who have cancer-related pain. So let's just briefly talk about my outline here. First, as I mentioned before, we're going to explain a little bit about what pain is. I mean, obviously we all know what it is. We've experienced it ourselves, but I'm going to go into a little bit of the science of pain and explain, for example, some of the brain pathways in the experience of pain. Then we'll transition to talking about integrative medicine, the types of pain in cancer, and the outcomes of studies on pain and cancer, and then of course focusing more on the types of treatments that have been used in terms of complementary integrative therapy for pain and cancer among adults and children. And then we'll spend a little time talking about the research. So first of all, as I mentioned, we're all interested in what exactly is pain, what is it all about? And there's been a definite evolution in terms of the science of pain and our thinking about how pain is experienced by people. If you see the old model, you know, basically it's just a one-way path. You put your hand on a hot stove and the nerves send the information to your brain and you experience pain. Ouch, right? Well, more recently we've discovered that actually there are a lot of downward sort of central influences that can modulate how much pain a person is actually experiencing. This was started in the 70s with what was called the gate theory. So as pain signals go from the periphery, your hand, up to your brain, the gate is open and you experience pain. And then when you remove the noxious stimulus, the heat source, whatever, the gate is shut and then pain is dissipated. But we've also more recently seen that this is a very complex system, that in fact your prior history with any kind of pain stimulus, your anxiety levels, your expectation for how much it's going to hurt, those things all influence how much pain you actually experience. Those are the psychological aspects, but there's also several biological aspects, neurochemical, structural changes in your brain, genetics. Those all influence how much pain you experience and how vulnerable you are to the experience of pain. So as you see from the diagram, the more modern conceptualization is that you have signals, nerve signals that travel from your hand, let's say, where you touch the fire up to your brain, but you also have descending modulatory influences that can damp down the pain or can amplify it. And so as in the slide it shows, it's a bidirectional process. And it's very complicated. We're still grappling with it, but we have a little bit better idea of what's going on now through brain imaging and also laboratory studies. So let's look at the brain itself, and we've gotten a little bit better now about understanding how pain is processed and the pain matrix, as it's called. So this is just sort of a diagram of, for example, descending modulation. So the brain is able to modulate, to reduce, or perhaps even amplify pain signals from the periphery. So just, I don't have a pointer, but, or do I have a pointer? Is there a pointer? Oh, yeah. Okay, so we'll start here in the prefrontal cortex. This is the area for judgment, higher order functioning. Your higher order thought processes are sort of not totally based here, but this is a center for them. And then we go, and then, so the signals usually come from the periphery through the dorsal horn of the spinal cord, and then they travel up. But then we also, like I said, we have descending modulatory influences. So the brain is able to make judgments up here about how threatening or how noxious a stimulus is. Then the anterior cingulate cortex becomes involved. This is a seat for regulating autonomic nervous system processes, blood pressure, et cetera. The signals are sent further to the somatosensory cortex, or SI, and these centers process sensation within the body, how sensation is experienced. And then through the thalamus, which acts as kind of a way station to process all of these signals. And then the periaqueductal gray, which is the major control station for descending modulation, down through the dorsal horns of the spinal cord. So how do we know that there's some descending modulation? Well, of course, we have brain imaging studies, but we also have laboratory studies involving what's known as conditioned pain modulation. And what that involves is when you have a pain stimulus, say, on one side of the body, and then another pain stimulus, a second pain stimulus, that the experience of the second stimulus somehow is able to dampen your experience of the first pain. So in other words, something is going on where the first pain is dampened by the experience of a second pain, which suggests that there's something happening up in the brain. It's not just what's happening out here in your fingers. If we look at brain imaging studies, we also see that there's other areas involved, like the amygdala, which is a main center for processing fear and emotion, as well as some of these other areas. So let's move now to integrative medicine. Obviously, all of you here are probably very familiar with it, but if we think about the fact that your brain and how your experiences are, what your experiences are, can shape your pain experience, then integrative medicine makes sense, right? It's not just the amount of insult to your tissue that results in pain. It's also your history, your mental state, your anxiety, your expectations about the pain that modulate it. And how do we know this? We know this from studies that have shown two people side by side with the same amount of injury to their spinal cord who report completely different levels of pain. One person can have what looks like a horrible insult to the spinal cord, but he or she may report very little pain, almost no pain. The other person can have very small amount of insult to the spinal cord and yet report horrible pain and be unable to walk. So what's going on here? Clearly, mental processes are involved, and clearly there's a role for psychological and mind-body influences. And because of these observations in sort of the medical literature, we know that self-report from patients is a very important part of pain. In many areas of medicine, what's thought of as being the gold standard is usually some kind of biochemical marker. Maybe it's your blood test or some other quote-unquote objective measure. But when it comes to pain research, we are very cognizant that the patient's report of pain is one of the most important, if not the most important, indicator of how much pain he or she is experiencing. And that's very different from many other medical conditions. And that's why pain is probably the reason that people use integrative medicine, the most common reason is because of pain. Because it's such a complicated experience that's shaped by so many different factors. It's not just whether your blood test levels show a certain amount of cholesterol or this or that. You've got to really attack it from all sides. And that's why we see here, for example, that, oops, didn't mean to do that. We see here, for example, that a comprehensive approach involving both conventional and alternative therapies works best. And especially in a case with cancer where there are so many emotional and psychological aspects that can impact well-being and also disease progression. Although, that's harder to prove, but certainly people's optimism, their degree of willingness to engage in helpful therapies is a very key part of their recovery. So as shown in this diagram, we really want to include the whole gamut of therapies when we're targeting people who have cancer, and particularly with pain, because pain is a very significant part of the cancer experience, not only the cancer itself, but also the treatments for cancer. And recent studies show that 47%, a very high number of people who are diagnosed with cancer, do use integrative therapies. So I'm not sure if this may have been discussed at prior talks, but the National Institutes of Health have recently changed their nomenclature for complementary and alternative medicine. So for the center that's responsible for funding the research into integrative medicine has recently changed its name from National Center of Complementary and Alternative Medicine, or NCAM, to National Center for Complementary and Integrative Health. And this change sort of encapsulates better the more modern thinking about integrative medicine. Alternative, I think they dropped it because it really didn't suit what we now believe is the best approach to complicated conditions like pain. Integrative medicine, on the other hand, has been described as a comprehensive interdisciplinary approach to treatment, prevention, health promotion, et cetera, that brings together complementary and conventional therapies. So again, the important part is that we want to work together with allopathic medicine, especially when it comes to cancer, because those treatments are still considered the front line. However, when it comes to wellness, quality of life, psychosocial support, definitely for that, we definitely need to return to more integrative approaches. So let's just spend a little time discussing the types of cancer pain. These are a little bit different because with cancer there are so many different diseases and so many different side effects from treatments. One of the common side effects, for example, if you have a sarcoma, often there will be an amputation to get sarcoma being the soft tissue tumor. So often if you have a lower leg sarcoma, there will be an amputation up below the knee. Is a better way if you can get it below the knee. And there can be, as a result of that, phantom limb pain, which is people reporting still feeling pain even though their limb has been amputated. So this is often the case, as I said, with amputations. And it's basically due to the nerves in the amputated limb still being stimulated. And that's why it causes what's called neuropathic pain, nerve pain. And this nerve pain has been described as being burning, shooting, stabbing, electrical, and can also be associated with what's called allodynia, which is extreme sensitivity of the skin. So people who have allodynia a light touch may produce excruciating pain. Another type of pain has been termed nociceptive. This is often described as being aching or throbbing, that it just hurts. This is often associated with some of the painful procedures in cancer. Myofascial pain is also common, so that can be experienced as kind of an aching pressure or cramping, pain with moving activity. And the fascia really connect all your muscles and tissues, and so obviously if you have myofascial pain, it can be very painful, and some people get headaches even due to tightness and straining of the fascia in the head. So there can also be hollow organ obstruction, for example, partial bowel obstruction that can lead to cramping, nausea and vomiting, which are also very common side effects of chemotherapy. Bone pain as a result from tumor or bone metastases can also occur if someone has that type of cancer or leukemia. And this is often experienced as very deep, aching, a feeling of pressure, tenderness. And then I guess there's also arthritis pain, which can be a combination of bone and nociceptive pain. So as I briefly mentioned before, cancer pain can result from many sources, but medical procedures associated with cancer is actually probably one of the top sources of pain in people who have cancer, which is unfortunate because obviously we want to try to destroy the cancer, but the problem is that we often end up causing lots of unwanted side effects, one of which is severe pain. I mentioned already neuropathic pain, which can result from amputations and phantom limb pain, visceral pain, pain in the viscera, bone marrow transplant, which can result in mouth pain, mucositis, so when you develop mouth sores. Obviously, the tumor can grow and press on other organs or other tissues, causing pain. There can be increased pressure in the head from certain procedures. And then, of course, as I mentioned before, anxiety, depression, fatigue, insomnia, these are all both side effects from treatment, but they can also worsen any pre-existing pain. So more recently, researchers in the cancer field have identified what they call the symptom cluster of cancer, which involves pain, fatigue, and sleep disturbance in people who are living with cancer. So the observation is that people living with cancer tend to have these symptoms co-occurring together, and they all impact each other and make each other worse. And obviously, if we don't try to manage these symptoms well, the symptoms can lead to worsening of mood, worse quality of life, reduction in functioning, and then lower adherence to therapies, which can, of course, negatively impact the course of the disease. So here is a sort of diagram that shows a symptom cluster, and we can see here it's kind of a vicious circle. Oops, keep doing that, sorry. You can see here it can be a vicious cycle where often treatment involves the administration of opioids for the pain. But of opioids, as many of you know, if you've had it after a dental procedure or some other medical procedure, definitely leads to tiredness, fatigue, and that can, of course, lead people to want to nap during the day and not do much. Nobody wants to go out and run 5 miles after they've taken opioids. But it also impacts nighttime sleep, which is the time when, of course, the body primarily repairs itself, which then leads to increased fatigue in the day. And fatigue does also increase sensitivity to pain. So you get more pain, what do? You take more medication, and then on in this terrible vicious cycle. And so this kind of diagram shows why just relying on traditional therapies like medication is not an optimal approach for people who live with cancer. An optimal approach will involve more mind-body and physical activity as tolerated to break this cycle and the reliance on opioid medications to manage pain. So many of the approaches for cancer, integrative approaches for cancer, have probably been discussed before, but I will sort of review them quickly here. Relaxation, of course, is good. Hypnosis or imagery, as I mentioned before, Dr. Zeltzer has done some of the seminal work in the 1980s using guided imagery to help kids who are undergoing spinal taps or bone marrow transplants. So her preferred approach was to, and kids are actually very good at this because kids are actually better at using their imagination than adults, and they're able to get lost in imagery. And she was able to very successfully get children to imagine themselves in play or other, very immersive experiences. And of course, this is before virtual reality. Now we have virtual reality, and there have been a lot of studies actually doing that. But children are able to do this very well with sufficient guidance. And often they were able to tolerate these procedures even without added anesthesia, because they were able to recognize the point at which they were so deeply immersed into the play or the scene that was when the procedure was done. They would signal when it was time, and then the therapist would do the injection or do whatever it was that was needed. And then other studies have shown that, as I mentioned before, your prior history with a procedure has a big influence on how you respond. Other studies have shown that people who had more positive memories about procedures such as a bone marrow aspiration actually have less anxiety and less pain during the procedures. So we've shown that if you can do a very brief intervention to just reframe some of the memories of that procedure, it can be much less anxiety provoking and less painful for kids. So in addition to the hypnosis, there's of course coping skills training, as Dr. Ames talked about, and cognitive behavioral therapy, meditation, mindfulness. So being able to be present in the moment and not worry about the future, that can calm the autonomic nervous system, and that can also reduce pain. Music therapy, as Dr. Ames talked about, and as I just mentioned before, virtual reality. So there are a lot of new studies showing how using these headsets, kids can get lost in an immersive environment. So for example, with another population of kids undergoing burn treatment for burns, which is very painful, they would visualize being in a snow environment. And they would use snowballs to bat at the pain, they would throw snowballs at the pain. And they found that this actually reduced their pain during skin debridement, during burn treatment. So there's a lot that can be done now with technology. Just going back to the pain, fatigue, sleep symptom cluster, there haven't been any research studies yet on mind-body interventions. That's because this thinking is relatively new. But we do have some evidence that individual components of the symptom cluster can be targeted by interventions such as relaxation, which can improve pain and sleep disturbance, music, and also hypnosis imagery. So just looking briefly at the literature, the existing literature for integrative therapy for pain and cancer among kids, there are a number of studies. However, most of these studies weren't of very good quality. That's probably true of a lot of fields. It's very difficult, as you can imagine, to recruit and retain this population in any trial. Most parents who have to give consent for their children to participate are reluctant oftentimes to enroll their children in any kind of clinical trial. And of course, there are also ethical issues in terms of withholding treatment or withholding an intervention that may be efficacious. You don't want to, have people randomized to the placebo group who then, of course, do much worse. I mean, there's just an ethical component to it. And because, research on children has these kinds of considerations, it's just much more difficult. Many parents are so concerned about the kid having the diagnosis and getting through the treatment and just, getting everything done in their day. I'm sure those of you who are parents know this. It's just hard for them to understand or appreciate the importance of research. And I think that key factor has made it very hard for us to come up with more high quality studies. But, we have to press on, and hopefully as the word gets out that more of these approaches are helpful, maybe people will be more willing to enroll their children in these kinds of trials. So this is just a list of the types of procedures, the types of therapies that were examined in this review, which included 32 studies. So we have aromatherapy, art therapy, distraction, hypnosis, physical activity, touch therapy, and cognitive behavioral therapy. There are also some studies looking at psychological interventions for needle-related procedural pain. And distraction and hypnosis are probably the ones that have the most evidence. For adults, there's a lot more evidence, and basically there is some pretty good, reasonable data, I wouldn't say super good, but reasonable data that for anxiety and depression in people with cancer, adults with cancer, meditation, yoga, and imagery are beneficial. For pain, massage, healing touch, music therapy, physical training have all shown some promise. However, there's no good data on acupuncture, and there are many problems in terms of the methodology of these studies. Now, I think we need to go to the next set of slides. Let's see, sorry. I don't know why it's not. Kim. I just wanted to make, how do you?
Yeah, so this is the big screen.
Oh, okay, sorry. So there are many sources of bias in integrative medicine research. Of course, I mentioned the whole issue with subject selection. The only people we've studied are the people who are willing to participate, and that's usually biased toward higher SES, and also probably Caucasian, because there's a lot, as I'm sure you're all aware, there's a lot of distrust among many minority populations about participating in research, and so there's less data on non-white participants. We also kind of shoot ourselves in the foot because we want a very highly defined population when we have studies. We don't want a lot of comorbidity or other people with more than one problem because we're worried that we're not going to find good results. So that often limits the generalizability of our work, because most people who come in seeking help have many different problems. As Dr. Ames talked about, her patients have, they're on 5 or 6 different pills. They have lots of different problems, and in the real world, that's what happens. Whereas for clinical trials, often they want people with just the one thing that they're looking at. And again, the whole thing of those who accept and those who don't, that's going to bias what you find. And then the people who drop out, what happens to those people? They may be the people who are more stressed economically, financially, socially, and those are the people we actually want to reach, and yet they're the ones who are probably more likely to drop out. Most of the studies, or many of the studies, have only a single arm, so it's hard to get data compared to a control in these kinds of trials. We often just look at treatment versus waiting list control, which is not the greatest. Ideally, you want to have some kind of what would be called an attention control. So if you have a yoga study, they're getting attention and special treatment, and they're in a group, you want to try to control for that, perhaps in a group that meets for just support. And we don't have very much, we really don't have a lot of data on comparative effectiveness. So how does yoga compare to Tai Chi, for example? There are very few trials that have looked at that. And then just if we look at the analysis, some of those issues come up. We don't really have good methods of accounting for those who either didn't complete the trial or who didn't complete all the data points in the trial. So again, these are the therapies that we've been looking at, and I don't know, she included this slide for early acupuncture, one of the therapies that we haven't really looked at. Again, this is why we need research, of course. And then I think she just liked to include some nice pictures of young children getting massage. Yeah. Art and music therapy. Biofeedback, so using your own body to, for example, decrease your heart rate if you're hooked up to a machine that gives you a signal that changes each time you slow your breathing down, you learn to eventually relax and slow down your breathing, slow down your heart rate. Pet therapy, that's another new one. I think a lot of hospitals are starting to use this. Hypnotic analgesia. A loaf of bread. And then yoga, of course. So this is a picture of someone doing what's known as Iyengar yoga. I'm not sure if people are familiar with Iyengar, but it is a discipline that has been found to be uniquely suited for medical populations. It's quite different from what a lot of people think of as yoga. It's very prescribed. In other words, the poses are very exactly described, and a teacher has to be trained for 7 years before the teacher is certified. So it's a very, very rigorous type of yoga, and it also involves the use of a lot of props, so bolsters and pillows and such, so that people who have medical problems are able to be positioned such that they're not harming themselves, but they're still be able to get some of the benefits of the yoga. So it's very different from, when you go to a regular yoga studio and people are doing handstands or whatever. This is adapted for people with severe medical problems. And our program has done some work on the use of yoga for fatigue in cancer survivors, and we found that in a small group that patients have reported improvements in fatigue. So here's a little more. And you see even very young children can do it. As I mentioned before, it's a very precise practice, and everything is individualized to the individual patient, depending on the patient's ability to move, mobility, age, medical problem. We did a study with people, let me see, what was it? I believe it was people with rheumatoid arthritis, which is a systemic problem that can lead to even loss of limb. And there was a girl who had lost a leg, but she was still able to take part in the study because all the poses were adapted to her and the fact that she only had one leg. So this approach holds a lot of promise, but again, you know, it's hard to enroll people in these trials because it requires so much effort and it requires so much dedication on the part of parents to be willing to take children, especially, to a yoga class, let's say 2 or 3 times a week to get the benefit. And then, of course, if you have, you know, treatments, other treatments, it might interfere. So you have to be very aware of the status of the patient, what his or her medical condition is, and of course the commitment that it takes to be able to engage in this kind of treatment. You know, ideally, once people are at the survivors, you know, post 1-year survival, they will all be enrolled in something like this. But, you know, it's so hard to get that kind of acceptance, as I said, primarily from parents, because it does take a lot of time and dedication. So as we've talked about a lot before, there are a lack of high quality studies. A lot of the studies don't address some developmental issues. So you're not going to give the same type of treatment to a child who's 9 or 10, who might have unfortunately developed childhood cancer, to an adolescent. You know, a teenager is going to need a lot more independence, they have a lot more autonomy, and they're going to have very different needs and very different psychosocial requirements. And then, of course, adults are going to be a whole different population as well. We don't know which of these integrative therapies are effective for whom, when, and in what dose. That's what Dr. Ames was talking about as well, the dose response. And what are their risks? There are likely to be some risks. Yoga, despite all the fact that, you know, we are very careful, there's still going to be some risks. We've never personally had any serious adverse events, but there's always the possibility, so we have to be aware. And then again, the timing of the treatment. When is the optimal time for people to engage in these therapies? At what point post-diagnosis or post-treatment in their survivorship should they participate? These are all very pressing questions that we haven't answered yet. Thank you. Do you have any questions? Oh, sure. Right, so the question is, have we looked at children who receive these interventions in childhood and whether they are able to have better outcomes in terms of pain in adulthood? Is that the question? I mean, that's a great question, and I think it's something that we would love to do. But these longitudinal studies are very expensive to do, and we haven't really looked at that. What we do know is that children who have chronic pain in childhood are much more likely to have it, unfortunately, in adulthood. And so that obviously underscores the importance of finding interventions that could prevent that from happening. But yes, it would be great if we could do that. No? Okay, thank you very much.